Hello everyone, myself Dr. Prashant, and today we are going to discuss this topic, slip capito-femoral epiphysis in pediatric orthopedics. And something that we should know first about this topic is that this name SCFE, that is slip capito-femoral epiphysis, what does it mean? This means that capito-femoral means head of femur. And what does epiphysis means? A part of head above physis. So in this condition, the epiphysis of femoral head slips. Is it really so? No, this is a misnomer. In this condition, head doesn't slip, but this is actually the metaphysis which slips. And relative to this, head appears to be slipped. So now we will be discussing this condition in detail. This diagram is showing that the metaphysis of the femoral head is going in superior, lateral, and anterior direction in relation to the head. So relatively head is going medial, inferior, and posterior. And we have already discussed that this condition is a misnomer. This is basically the metaphysis which slips, not the head. Head is slipping relative to the metaphysis, not actually. So this condition appears to be similar to type 1 Salter-Harris fracture. But why are we discussing this entity altogether as a different entity known as SCFE, but not as a trauma, that is type 1 Salter-Harris fracture? Because in trauma, that is type 1 Salter-Harris fracture, the physis is normal, but the force is abnormal, which causes injury, and so the slip happens. But in this condition, what is the difference? The difference is that the physis is not normal. Physis is sick and the load is physiological. Patient is just bearing the weight on the limb. This is not a trauma, not a supra-threshold force acting over this region. So this is the reason why we are discussing SCFE as a separate entity, and this is not equal to type 1 Salter-Harris fracture. Okay. So why is this physis sick? What makes this physis sick? So there are certain mechanical factors and certain biological factors. We will be discussing these factors. The first one mechanical factor is that when we see this diagram, which is shown in this image, between the epiphysis and metaphysis, between these regions lies the physis. Okay, and a ring that is known as perichondrial ring connects epiphysis with the metaphysis so that there is a stability component in between the two which doesn't allow physis to slip with relation to the metaphysis. But in these patients, this mechanical perichondrial ring is weak, which causes epiphysis and metaphysis to slip with respect to each other. This is one mechanical factor. What is another mechanical factor? In these patients, the physis is many a times more vertical. The orientation of physis is not this way, but more vertical, which predisposes the physis to go into the phase of slip with the physiological loading. Whenever the physis is more vertical, this normal physiological loading will act as shearing. So this shearing force can lead to the slip at the physis whenever the physis is more vertical. Now coming to the biological factors, whenever a child is suffering from endocrinological disorders, what these endocrinological disorders could be? Like growth hormone disorders, pituitary hormone disorder, gonadotropin disorder, renal osteodystrophy. In all these conditions, the physis of these patients is not normal, but the physis is sick. In all these conditions, the physis can have tear inside the zone of hypertrophy and patient can have slip, that is slip capito-femoral epiphysis. So one entity we have discussed right now is what is the site of slip. In SCFE, the site of slip is zone of hypertrophy. What this zone is? Normally when we draw zones of physis, what all these zones are, this is epiphyseal side and this is metaphyseal side. So the zones of physis from epiphyseal sides are zone of resting. Then comes zone of proliferation, the zone where most of the cells will proliferate. Then zone of hypertrophy. Once the cells have proliferated, individual cells will increase in size in the zone of hypertrophy. Then comes the zone of provisional calcification. Once they have calcified, they will go toward the side of metaphysis and mature bone forms. So these are the zones of epiphysis, and in which zone the slip is happening? This is a zone of hypertrophy where slip happens in SCFE. Okay. So what is the deformity in these cases of SCFE? We should be knowing that since this part of the bone is going in lateral, anterior, and superior position, it leads to extension of the limb along with obligatory external rotation. So this is basically varus deformity of this limb, varus displacement, which is most commonly found in SCFE, which leads to external rotation extension deformity. So this is a deformity which is found in this patient, and along with these, you should always keep in mind that SCFE is a painful condition. Yes, it does present like a fracture, but this is not a fracture. And why this is not fracture, we have already discussed. What makes SCFE a different entity from Salter type 1 fracture that I have already explained to you. So this is the presentation of the condition. Now coming to the radiological findings. The commoner radiological findings are, the first one is, since the physis is not normal, it appears irregular on X-ray. The images of all these radiological findings we will be seeing in further slides, but at this stage, for your better understanding, I'm trying to explain and correlating most of these findings with the pathophysiology. Okay, an epiphysis is generally smaller in size, that is, reduced height of epiphysis. Apart from that, we have Trithoven sign. So what is Trithoven sign? Whenever we draw a smooth line along the superior margin of the neck, this generally intersects the head like this. This line normally intersects the head whenever there is no slip. But after the slip, as you can very well see in this picture, the head is lying over this region, and the line along the superior border of the neck is no longer intersecting the head. And this is what we call as Trithoven sign. So I hope all these findings are clearer to you. Apart from these findings, there are few more that I should be explaining to you. This is the posterior wall of the acetabulum. I extrapolate it over this region. So with the red, I am showing you posterior wall is present over this region behind the metaphysis, as I have already shown you with extrapolation. And over the same region, metaphysis is also present. Okay. So in normal individuals, this is the area where you will see radio density because of superimposition of posterior wall of acetabulum with metaphysis of femur. This is normal. But whenever the metaphysis slips in supralateral direction, superimposition is no more there, because of which a lucency can develop. over this region, and this is known as sham or Kapner sign. How does it look? We will be seeing in further slides. Apart from this sign, we do have one more sign. In normal individuals, metaphysis and epiphysis do not overlap. But once metaphysis slips, there could be overlapping between head and metaphysis. They can superimpose over each other, and over the superimposed part, you can have radiodensity. This is known as Blanch sign. Okay. So radiological findings I have explained to you. Now we will be discussing most of these facts in detail in further slides. So the condition is misnomer, I have already told you. And this is the metaphysis, which slips in antero-superior-lateral direction, but not the head. Head is relatively slipping in posterior-inferior direction. Most of patients do have some endocrinological disorder. As you can see very well in this picture, the child is an obese child, and mostly these are male child around puberty. So these are adolescent male children who are obese. This is general presentation of a SCFE when they present with pain around the hip. Okay, and in nearly 20% cases, the condition is bilateral. It can involve both the hips. So we have already discussed more common in males who are adolescent, obese, and bilaterality in 20% of the cases. Pathophysiology, we have already discussed. The slip occurs in the zone of hypertrophy. This is normal, and right-sided is abnormal. That is SCFE. So from the epiphysis moving toward metaphysis, I have already explained. This is the zone of resting where cells are scattered all around, zone of proliferation, where the cells are arranged in columnar arrangement in normal individuals, zone of hypertrophy, where cells have hypertrophied. This is the reason where the slip occurs. Then zone of provisional calcification, and here the mature bone is led down towards the metaphysis. But in abnormal, that is SCFE condition, the arrangement of the cell in proliferation as well as hypertrophy zone is distorted. This is what makes it different from the normal. So the slip will happen in zone of hypertrophy. This is how the pathophysiology of SCFE looks on histopathological examination. I have already told you there are some mechanical factors and some biological factors which we have already discussed. Endocrinological disorders which are most commonly associated with this condition are thyroid disorders, growth hormone disorders, renal osteodystrophy, and pituitary hormone disorders, that is panhypopituitarism. Site of the slip, I have already told you, this is zone of hypertrophy. Direction of the slip, most commonly varus, because of which the limb goes into external rotation and extension. Whenever the valgus is the direction of the slip, that is very rare. The limb goes into flexion with external rotation. Okay. Coming to the classification part, there are various classifications which have been defined for SCFE, but one we should be discussing right now is temporal. Temporal classification divides SCFE into pre-slip stage, when only prodrome of symptoms like pain is present but slip is not there. Then acute slip within 3 weeks presents like fracture. Acute pain, very severe pain. Then chronic slip after 3 weeks. Ultimately, pain reduces or may even subside too. But child continues to have limp, and sometimes limb line discrepancy might also be there. Okay, so this is the temporal classification: pre-slip, acute slip, and chronic slip. Another one classification that we should keep in mind is loader classification. That is very much important. Why is it very much important? Because it tells us about the why is it very much important? Because it tells us about the stability of the slip. What does stability mean? Whether it is able to sustain physiological load or not. If can sustain physiological load, this is stable. 95% cases are stable only, and there are very low chances of avian in these cases. But sometimes physiological loading cannot happen. Child is not able to walk at all. These are only 5% of the cases only, luckily. And in these cases, very high chances of avian. Sometimes even up to 50% chances of avian are there. So stable slip, more than 95% cases are stable, fortunately, and there are less chances of avian. Unstable, I already told you that there are very low number of cases, but high chances of avian. Now the third one classification is Southwick's classification, which tells us about the severity. In this classification, we do calculate slip angle. What slip angle is and how to calculate, I'll tell you in next slide. But you should keep in mind that whenever the slip angle is less than 30 degree, this is mild. And whenever this is 30 to 60 degree, it becomes moderate slip. And the severe slip is whenever the slip angle is more than 60. So this is how Southwick classification is defined. And how do we calculate the slip angle? On the right side, we have normal hip, and on the left side, we have SCFE. So we draw a line along the shaft of the femur and another line which connects two ends of the physis. Okay. And one more line which is perpendicular to the line which was connecting two ends of the physis. So the angle between a line along the shaft of the femur and a line which was perpendicular to the physis. Okay. So this angle is calculated on the normal side, that is theta 1. And the same angle is calculated on the diseased side also, that is theta 2. And we calculate the difference of the two. This is the slip angle of Southwick. Whenever this theta 2 minus theta 1 is more than 30 degree, this comes under the category of moderate, and whenever more than 60 degree, this becomes severe. Now we will be calculating Southwick angle for this condition. So this is the normal side. On the normal side, and this is a line along the shaft of the femur, and this is a line along the physis, and line which is drawn by red is a line which is perpendicular to the physis. So theta 1 is the angle between the two. And similarly, on the affected side, they have drawn a line by red along the physis. Similarly, a line perpendicular to this line. And by the green, I am drawing a line which is along the shaft of the femur. So this angle is theta 2. So obviously, theta 2 minus theta 1 would be the Southwick's slip angle. Similarly, in this diagram also, we can calculate the angle. One more entity, that is Barrios angle, we should keep in mind. Barrios angle is almost similar to Southwick's angle. The only difference is in this condition, we are going to draw a line along the physis, 2 points of the physis, but this time we are going to draw a line which is perpendicular to the line along the shaft of the femur, not perpendicular to this physial line. Okay, so we have drawn a line which is perpendicular to the shaft of femur, and we have drawn already a line along the physis. So the angle between the two is the Barrios angle, and whenever this angle is more than 14 degree, then the chances of contralateral slip are more. So this tells us when we should be doing prophylactic pinning on the opposite side, that we will be discussing in further slides. Alpha angle is also an angle which is calculated on frog lateral view. We draw a perfect circle around the femoral head on frog lateral view, and we see where this circle does intersect the neck of the femur, at which point the neck of the femur is entering or intersecting this circle. At that point, we draw a line from the center of the femoral head and one line along the shaft. And this angle, theta, is the alpha angle. And whenever more than 50 degree, this again is suggestive of contralateral slip, higher chances. Okay. So we have explained both Barrios angle and alpha angle. In this condition also, you can calculate alpha angle. Supposingly, this was a normal condition where head was in its place and metaphysis was also in its place. Definitely, we do know the point where the neck would be intersecting this circle would be somewhere at this point. Whenever this metaphysis slips in this direction, the metaphysis would come somewhere over this region. So now this circle would be intersecting metaphysis somewhere over this region. And when we calculate the alpha angle, this would be definitely alpha 2 would be more than alpha 1. So this is how alpha angle is calculated. And why does alpha angle more than 50 degrees suggestive of higher degree of slip and hence higher chances of contralateral slip? We have explained that fact. And in this diagram also, we have shown that how when the patient does have slip, the alpha angle does increase. So I will be drawing a perfect circle along this femoral head like this. So this is a point somewhere the neck is intersecting. So head of the femur. So this would be the theta, that is alpha angle. Now, clinical presentation, I have already told you this is a painful condition where the child presents with painful limb. And what is the age of the child? This is generally 10 to 12-year-old child. In males, nearly 12 to 14 is the age when they attain puberty, and in females, 11 to 13 is the age when they attain puberty. So, nearly 1 year after, that is 13 to 15, and that is 12 to 14. This is the age when they does have growth spurt. This is the most common age when these children are likely to have SCFE at around the age of growth spurt. And you should always keep in mind that nearly 20% of children do have knee pain, not the hip pain. And why is it so? Because of obturator now. They can have radicular pain. This is radicular pain. In 20% of the children, knee pain is the sole presentation of SCFE, not the hip pain that you should remember by your heart. So this is a painful hip condition. Attitude of the limb, we have already discussed. Extension with external rotation. They can have limb line discrepancies also. And in 20% of the cases, I have already told you, the child does have knee pain, not the hip pain. One more condition, one more finding I will be telling you. This is the obligatory external rotation that is found in these children. Whenever you try to flex the hip on the affected side, usually what happens, you are able to bring the knee of the affected side to the contralateral shoulder. Okay. But in these children, you are not able to do so because while bringing this knee to the contralateral shoulder, you are internal rotating the hip. And in the children with SCFE, you cannot have internal rotation because their attitude of the limb, because of the deformity, is obligatory external rotation. So whenever you try to flex the hip by on its own goes toward the axilla of same side. That is because of obligatory external rotation, as you can see in this diagram. And what is the name of this sign is Dreeman's sign. This is obligatory external rotation of the hip with hip flexion, Dreeman's sign, and this is also known as axis deviation. So X-ray findings that I have already told you, we will be seeing these findings on X-ray images now. So one finding was widened epiphysis, I have already told you. Another was irregular physis, and one was reduction of the height of epiphysis. Trithoven sign I already told you, and these two fancy names I told you, these was Shams sign or Kapner sign, and one was Steele sign of Blanche. And how does these findings look on radiograph? I'll be showing you. So in this radiograph, definitely right-sided hip is the affected one. You can see that the height of the epiphysis in this side and in this side you can compare. Obviously, B is more than A, so the height of epiphysis on the right side is reduced. One more thing you should be noticing in this thing is over this region, you can see radio density because of overlapping of posterior wall of acetabulum with the metaphysis. But compare it with this side. This is sham or Kapner's sign. This radiolucency. Sham Kapner sign is radiolucency, and Blanche sign is radio density. So you should know that one sign is about radiolucency, one is about radio density on the affected side in SCFE. Okay, one more thing you should keep in mind that on the affected side, you are able to see generalized osteopenia of proximal femur. Compare it with the opposite side. In this side, this is normal, and in this side, you are having osteopenia in all this region. That is also a sign which is seen in SCFE. Coming to the next radiograph, this again is showing reduced height, irregular physis, and osteopenia. All these are the findings, and again, sham sign. Coming to the next radiograph, this is showing metaphyseal Blanche sign of steel. Over this region, you are able to see radio density. This is the sign of radio density versus what was radiolucency? That was sham or Kapner sign. Okay. Now coming to the next one. This X-ray is showing gross displacement. Obviously, slip angle would be somewhere more than 60 degrees. This is severe slip. Okay. On USG, you see this sign known as step sign because of the slip. So step develops between metaphysis and epiphysis. Over this region is somewhere physis is present. So this step sign is found on USG. Now coming to the treatment. What should be the aim of the treatment? Since the child is having pain, we should relieve the pain. Since the child is having slip and the relation between head and metaphysis is abnormal, try to correct this relation again. And once you have corrected this relation, try to maintain it. It should not slip again. Okay. So what should you do so that it should not slip again? Try to fix it. That is the concept of pinning, insertion of a screw. Okay. So stabilization options are, we can go for pinning, that is one screw fixation. We go for in situ pinning, that is without reduction. Whenever the slip angle is less than 35 degrees, there is no need to reduce it. Just put in situ pinning, one pin in situ. No reduction required because chances of development of a bump over this region will be very low if the slip is mild slip. In that case, you can just go for in situ pinning. Okay. If there is more than 35 degree of slip angle, and if you go for in situ pinning now, if you are not reducing it now, then the chances of FAI are more. What is FAI? Femoroacetabular impingement. That is one of the complications of SCFE. We will be discussing that. Now comes the concept of postural reduction. With the positioning of the child, whenever we flex and adduct the limb, with that positioning itself, sometimes the SCFE reduces. Then we can pin it. This is also one modality. And this is the modality we should be employing most of the time because reduction by force is something which is not recommended at all because it increases chances of avian. Okay. So close reduction and pinning, this is not recommended most of the time. Open reduction and pinning is recommended whenever the slip angle is more than 35 degree, nearly supposedly 50 degree. In situ pinning, not recommended because chances of FAI are more. In that case, we should go for open reduction, that is Dunn's osteotomy. Do Dunn's osteotomy, reduce it, then fix it with a pin. What should be the position of the pin and how many pins should we use? Only single pin. One pin is enough. It should be central. It should be perpendicular to physis and always keep 5 mm distance. So if this is femoral head and this is neck, and if you are putting a pin, that should end over this region only, leaving a 5 mm of subchondral bone. Why is it so? Because if you go too close to the articular cartilage, supposedly over this region, the chances of penetration of pin into the joint are high, and that can cause one condition that is known as idiopathic chondrolysis of hip. This is also a painful condition of the hip, which ultimately leads to ankylosis or arthritis of hip. We will be discussing this complication now. Before that, we should know that there are certain factors which contributes to the development of avian in SCFE. What these factors are? The most important is the stability of hip that we discuss in loader classification. Unstable cases, higher avian chances. Another one is severity of slip. Slip angle more than 60 degree, more avian chances. Apart from that, whenever you are doing forceful close reduction, more chances of avian. Whenever you are doing close reduction, more chances of avian. And whenever you are not treating untreated cases, more chances of avian. Okay. Now we will be discussing about idiopathic chondrolysis of hip. So it does have three definitions. One is clinical. Clinical definition is painful hip range of motion restriction. Okay, which can ultimately cause ankylosis or arthritis. This is one definition. Another is histopathological. In this definition, they say that cartilage undergoes necrosis. Another one is the radiological definition. That is more than 50% joint space reduction. Okay? But in unilateral cases, whenever the cases are bilateral, you cannot compare it with the normal side. So in this case, less than 3 mm joint space is left on both the sides. This is the radiological definition. So how does idiopathic chondrolysis looks on X-ray? You can see very well that this is the normal side where a smooth symmetrical joint space is present on this side. But in this side, you can very well see the joint space is reduced, obviously less than 50% as compared to the normal side. Child is definitely having painful hip. So this is a painful condition which is characterized by necrosis of cartilage on histopathology, which is characterized by reduction of more than 50% of the joint space as compared to the normal side, or less than 3 mm of the joint space is left whenever the case is bilateral, and ultimately it leads to ankylosis and reduced range of motion of the hip. So this is idiopathic condylosis of hip. What is the most common risk factor for idiopathic condylosis of hip? I have already told you. Whenever the pin penetrates into the joint. Okay. So this is a risk factor for development of idiopathic condylosis of hip. This is what I have already told you. Pin penetration is the cause. Hip spica application is also a known cause, but not that much important. And untreated cases also do develop idiopathic condylosis of hip. It is conservative management only. Some surgeons do believe that distraction around the hip can also be helpful in this condition, and some do believe that this is because of the higher pressure inside the capsule, so subtotal capsulotomy might also help. But the data regarding this is limited. Coming to the natural history of idiopathic condylosis, it does have better outcomes than avian, but obviously it can lead to ankylosis and reduced range of motion of the hip. One more complication is FAI, femoroacetabular impingement. I already told you whenever the slip angle was more than 35, and if we are not reducing CR or OR, if reduction is not done and in situ pinning is done, in this case, so a bump can develop over this region. Why is it so? Because if this is a femoral head and if metaphysis was slipping in this direction and we fixed it in this direction only, so this is the reason where the bump develops. And what we call this bump, this is the cam. So cam type of FAI develops in SCFE. And what is the management? How will you manage? You can remove this bump. No? This is known as osteochondroplasty. So just take this bump out. And in this way, you will be able to treat it. There are certain osteotomies which are defined. So just for the sake of completion, 3 osteotomies. Whenever you are just doing subcapital, that is, we have already discussed, Dell's osteotomy. Whenever you are doing it at the base of the neck, this is Kramer and Bermuda. And in intertrochanteric region, Southwick's osteotomy. These 3 osteotomies, at least their name you should know. Prophylactic pinning, I have already told you. Whenever a child is having the right-sided SCFE, when should you fix left-sided hip also? Obviously, whenever you are suspecting that there are very high chances of development of contralateral slip, what all these conditions are, whenever the age of the child is less than 10 years, the child is very young. Obviously, the age at which he will have fusion of ISIS would be nearly 15 to 17 years. So he does have a very long duration to go through before the physis fuse. So during this period, he is likely to have progression of slip. Okay. So we don't want to take risk. Just fix opposite side also. This is one condition. And another is endocrinological disorder. So whenever a child does have endocrinological disorders like delayed puberty, thyroid anomalies, growth hormone deficiencies, in that cases also try to fix opposite side also. And one thing which we have already discussed is alpha and Barrios angle, although not very important, but some authors do quote that whenever the alpha angle more than 15, Barrios angle more than 14, in that case also you should be doing prophylactic pinning. So now we will be discussing one case. So a 3-year-old female child who have complaint of painless limb, and she is the firstborn child to her mother, comes to our OPD. On inspection, we found that there are abnormal growing creases and limb length discrepancies there. On palpation, we found that increased umbilical lordosis is there, Galeazzi sign is positive, and on movement, abduction was reduced as compared to the normal side, and 2 centimeter true shortening was there. On doing spatial test, we found that Trendelenburg was positive and telescopy was positive. So what comes to your mind next? What could it be? Obviously, this is not SCFE. This is developmental dysplasia of hip. Intentionally, I kept this case with a SCFE. Not always you are discussing a SCFE and the case would be SCFE. It could be DDH also. Always keep your mind open. Okay, always try to interpret the case. Now this 14-year-old male with left knee pain into 2 months. Child is having knee pain since 2 months and having history of delayed puberty coming to your OPD. Now you are examining the knee, obviously, but the knee examination is unremarkable. So is the job done? No, I already told you. Always remember to examine the hip also because 20% SCFE cases do have knee pain, not the hip pain. So on inspection, we found extension, adduction, external rotation, attitude of the lower limb. Tenderness was present at the hip. On movement, restricted abduction and internal rotation as compared to opposite, and 2 centimeter tooth shortening was there. Child had axis deviation positive, and this was a radiograph. This is the case of SCFE. So this is all I wanted to discuss about SCFE. Thank you. I hope you found it.
Yes, sir.